Okay, so good afternoon, everyone. Thank you for making the time to join us this evening. My name is Dr. Ibrahim. I'm cardiology registrar in Sunderland Hospital. I'm organizer and program director of this event. So as you know, the COVID-19 pandemic is indeed the greatest and unprecedented global public health crisis facing our generation, and it is most frightening disease. It is frightening because the combination of the infectiousness and ability to cause a severe disease. So today, just would like to initially I thought to give a brief summary about our previous webinar, but I think for seeking time, I think we will skip this talk and we'll start directly with Dr. Veronica Smith, who with the Consultant Respiratory, by giving us update about respiratory representation of COVID-19, and then we'll move on to acute critical care management by Dr. Marcela, and then we excited to hear about this summary of trials and drug therapy in COVID-19 era. And then we'll have Dr. Linah. She will give us like a great talk about the emergency assessment and management of COVID-19 patient. And we will be having update about resuscitation of the COVID-19 patient by Dr. Emmanuel Ako. And also, I think the aim of this webinar to share the knowledge and experience from the expertise from different trusts from different countries to learn from each other. And I would like to thanks to our speaker today who are kindly agreed to participate and to share their experience and knowledge. And particularly also, I would like to thank the Chelsea and Westminster Hospital team for this very great initiative and for their cooperation to help us deliver this talk to our colleague in Sudan. Just we got a few reminders before we move to Dr. Veronica to start her talk. This conference will be recorded and we will be available later on YouTube. So I can see that the few audience now attending on Zoom, but later on will be available on YouTube channel and will be available also on Facebook later. So if you miss any part due to any technical issue, please don't panic. Still, you will be able to watch the whole event later on. And also, we would like to remind for those who is not talking, just to mute their microphone to minimize any background noisy during the presentations. And now I would like to take this opportunity to ask my colleague, Dr. Hatim Ali, to invite the first session speaker. Over to you, Dr. Hatim.
Thank you very much, Abdulaziz, for hosting this event and making sure it is the light. And I would like to extend all the special thanks to the team, Abby's team from Chelsea and Westminster. A distinguished talks and hopefully very, very useful for all of us and all the watching audience. Certainly we're trying to learn in Sudan, so I'm based in Sudan, we're trying to learn from the experience and the knowledge of people around the globe. And we were very lucky to be approached by the team to share the knowledge and experience of managing COVID, which has devastated all the systems. And obviously Sudan is not an exception to any of this. I think we have a lot of sessions today and talks. All of them will be very useful. So without any further ado, I think I'm going to introduce Veronica Smith. Veronica is a consultant in respiratory medicine based in Chelsea, and she is going to give us the first talk. So Veronica, the mic is yours now.
Thank you. So in the interests of time, I'm not going to go into any detailed pathophysiology at all. We were talking about wanting to share our experiences. So I thought I would try and share just a couple of cases really. Sorry. So the objectives are to talk through two clinical cases. I'll try and be brief, and then the learning from these cases. And I will very briefly talk about CPAP, but I'm not going to go into the settings, as I know there's an intensivist also speaking. So a couple of COVID cases that we saw early on during the experience. So the first case is a 65-year-old gentleman who had a long history probably more than 4 weeks of a dry cough, and was diagnosed with asthma a month prior to coming into hospital. Before his presentation, he had had 3 days of fever and breathlessness, the more classic symptoms of COVID. So we took that as the day 1 of symptoms, 3 days prior to admission. He had had a negative COVID test prior to coming in, and he was independent, lived with his wife, worked at Heathrow Airport as a baggage handler, but did not do any regular exercise. So his Rockwood Frailty scale was 2. I don't know if you're familiar with this scale, but this is a slide of the scale that we commonly use in our hospital for determining how fit somebody is. And there are some special inclusion criteria for people with dementia. So he was doing well on the scale 2 with no active disease symptoms, but not fit as in doing regular exercise. So when he presented, he did have a temperature, and he appeared to be in respiratory distress with a high respiratory rate and high heart rate. His oxygen saturations were significantly reduced on air, but came up on 4 litres of nasal cannula oxygen, and his respiratory rate improved to 24 with oxygen. On auscultating his chest, it was clear without wheeze on admission. And his results came back as positive for COVID PCR with white cells that were normal. There was a mild lymphopenia, and his D-dimer was high on admission with high inflammatory markers, including C-reactive protein, ferritin, and LDH, which we are commonly testing routinely for our COVID patients. So this was his chest X-ray on admission, which, as you can see, shows bilateral extensive infiltrates, despite not having any clinical signs on auscultation. And we felt that this was his day 3 of his COVID infection course. So because of his high D-dimers and inflammatory markers, and because we know of the risk of thromboembolic disease, he went on to have a CT pulmonary angiogram, which didn't show any pulmonary embolus, but did show extensive infiltrates with mid to upper zone predominance. And there's also traction bronchiectasis here, suggesting some element of more permanent fibrotic change. So the question was raised as to whether he had any underlying lung disease, despite not having a history of such. So he was treated with prednisolone because of his background of asthma, antibiotics. His respiratory rate remained high despite the oxygen, and his oxygen requirement slowly improved. However, his fever persisted to day 10, despite improvement of his C-reactive protein, and he deteriorated on day 10, requiring more oxygen, and was sent to intensive care. And he was intubated and ventilated for 7 days, but did not require any other ITU support, such as vasopressors or filtration. So he came back to the ward on day 18, and he suffered a number of post-ITU complications, including keratitis in the eyes, critical care neuropathy and delirium, and pressure sores on the buttocks. He hadn't had his bowels open for several days and had an ileus, thought to be due to electrolyte disturbance. And at that time, the decision was made that he was in fact too frail to be considered for re-escalation to the intensive care department because of his deterioration in overall health status. During his ITU stay, he had rising D-dimers above, in fact, 20,000. That's a typo there. So he went on to have a further CT scan, which showed pulmonary emboli, which had happened over the course of his intensive care stay, and a large iliac vein thrombosis, which was treated with anticoagulation. And this was his CT scan on day 18 of admission. So you can see there has been some evolution of the CT changes and less dense consolidation, but there remains significant abnormality throughout the chest. So this gentleman was discharged to a rehabilitation care setting on day 39 of his illness. and he had significant morbidity relating to his ITU stay, including poor mobility, an infected pressure ulcer, and ongoing worsening breathlessness, and a urinary tract infection which was treated. So he is still undergoing rehabilitation at this time, and his family have complained to the hospital because they're unhappy with the outcome. I'm just thinking about the case series that was published in the Lancet by Zhou et al. They looked at about 190 odd patients and their clinical course, and we can see in the survivors that their initial symptoms were cough and fever, and they didn't develop the dyspnea until day 7. And on average, their patients were discharged a little earlier than this gentleman at day 22. In the patients that didn't survive in their paper, they tended to have an earlier deterioration at day 12 and develop sepsis a little later at day 10, which this gentleman experienced. So I think it's worth thinking hard about the patients that we select for intensive care, and I think that has been a real learning curve during the COVID period in the UK. So I'm going to go through a second case. So this is a 74-year-old female who had a history of 5 days of diarrhea and vomiting, and 3 days of fever with dry cough. We took that as her first day of symptoms, 3 days prior to admission. And on admission, she was very breathless with increased work of breathing and oxygen saturations of 88% on high flow oxygen on a non-rebreathe bag with a respiratory rate of 34. She had significant comorbidities, including type 2 diabetes, previous lymphoma, and a previous right lung lobectomy. She was on amlodipine, ramipril, and atorvastatin. And although she was fit, she cared for her sick husband at home. But in terms of the Rockwood Frailty score, she scored a 3. So she didn't do any significant exercise. She'd never smoked and had no previous other respiratory conditions. So this lady tested positive for COVID. And just looking at her admission blood tests, her white cells were normal on admission. She had a mild lymphopenia again, and a significantly raised D-dimer. Her inflammatory response was not as marked as the previous gentleman, but nevertheless was increased. So this was this lady's admission chest X-ray, which again shows typical changes of COVID-19 with bilateral pulmonary infiltrates widespread. And this was the CTPA she had, so there was no pulmonary embolus demonstrated on the CTPA, but there were extensive ground glass changes with also this crazy paving pattern with interlobular septal thickening, which is commonly seen, and there's evidence of previous surgery and volume loss on the right side due to previous lobectomy, and I suspect the scarring is long-term relating to that. And there's another slice, so this is throughout the lung fields. So this lady came in, and on admission, we decided early on in the admission that thinking about escalation, she should not be for cardiopulmonary resuscitation in view of her comorbidities and her frailty score, despite the fact that she was fairly independent. It was decided that this lady would not benefit from intensive care treatment. And on reflection, thinking about the effect of COVID on different age groups, it was felt that she additionally wouldn't be a candidate for non-invasive ventilation on the basis of the constellation of age, comorbidities, and frailty score. So it was decided that this lady would have a ward-based ceiling of care. And this is some data from late March based on figures from Italy and China, which shows the percentage of deaths in the lower bar here in the different age groups and the cases requiring hospitalization in percentage based on the different age groups. Whether that was the right decision or not, I'm still undecided. But the clinical course, so she had bacterial infection treated, and her respiratory distress slowly improved whilst on the ward. She was alert and feeling better in herself. Her oxygen saturations remained very low, despite the 15 litres of high flow oxygen. And it was decided that she was very unlikely to survive this episode, and there was a compassionate care agreement decided, which means that we were going to focus on her care, expecting her to deteriorate and eventually pass away. We would support her in this process. And this was her repeat chest x-ray. Despite the fact she was feeling better, there were more extensive changes on the chest x-ray supporting progression and worsening of her condition. So on day 18 of her illness, she was discharged to a hospice on high flow oxygen and expected to pass away in the coming days. However, she actually gradually improved during her 4-week stay in the hospice, and surprisingly was able to gradually wean off the oxygen, and was in fact discharged home after a number of weeks in the hospice. So she's actually doing very well, I understand, at the moment, and this was a lady who was not expected to survive, and a lady that we didn't offer any sort of respiratory support beyond oxygen or intensive care treatment. The fact that she's female obviously went in her favour, and she actually has done very well, which I think the learning from this case, I think we have to be very careful about the treatments that we select for patients, particularly when we need to be mindful of resources. This has been a huge concern in the UK. So just moving on to talking about ward-based respiratory support. I'm not going to go into any detail because I know Marcela is going to be talking about her view from the intensive care perspective. But these are just some pictures of our wards of people in their full aerosol generating procedure PPE, with the visors, the face masks and the gloves and full-length aprons. So thinking about respiratory support for our patients, I think one of the most important things has been ensuring that the patient escalation decisions are made very early on when we meet the patients, and taking into account the frailty of the patients and the comorbidities as well as age. We were very concerned in our hospital at the beginning of the COVID crisis about running out of oxygen. And in the interests of conserving oxygen, I would recommend starting on low flow nasal cannulae and then using the Venturi at 35% as the escalation in order to conserve the hospital's oxygen supply. And then the non-rebreathe mask can be used if patients are still desaturating. And then for patients that are considered suitable for escalation of care, for example, to non-invasive ventilation, and by that, we have only been using CPAP. So we've not been using high flow nasal oxygen, and only seldom have used the bi-level BiPAP support. So in patients that are requiring more than 40% FiO2, or who have obvious increased work of breathing despite having a lower FiO2, I would advocate starting the CPAP therapy early. And I think we treated about 40 patients in our hospital with CPAP on the ward, and 18 of them have survived, and including 9 of the patients that were for full escalation, 8 of them avoided intensive care, and 1 of those patients went to intensive care and unfortunately died. So I think, although it's anecdotal, I would support early use of CPAP as an intubation avoidance strategy for patients that are for full escalation. And I've just put a link here for our government recommendations on personal protective equipment for aerosol generating procedures and general for care of patients with COVID-19.
Thank you, Veronica. Can I interrupt? Is that okay?
Yes.
So I think that, I really feel very uncomfortable about the triage system.
Yes.
Because basically, where no foundations is true in the UK and around the globe, people
Yes.
know what the Chinese team or group were presenting at the very beginning when they said that age, multi-organ failure, and high Alzheimer condition were the factors that will contribute to mortality. So lot of people, not only in the UK, but around the world, started triaging. Say if you are a bit old or you got comorbidities, you will not benefit from hospital admission or admission to intensive care. So there were some guidelines that were put here and there. Probably all of you or some of you know the VIP study. That was one of the major clinical studies in Europe looking at old people, admission of old people into intensive care, so people more than 80, and benefit of these people of coming into intensive care. And clearly, it's not about age to start with, and secondly, it's not about comorbidities either. It's about the physiological response of the individual to a medical condition. So from the very beginning, and actually I was very vocal about this situation, not at local level, but at national level, and I've been in contact with Chris Whitty and with the team that were running with the president of the Intensive Care Society. I wrote a letter that actually I shared now with all of you, where
Yes.
I did analysis of the mortality that was presented at national level in intensive care, and I actually did the analysis, dissected the VIP study, where clearly I showed that we must not triage. That was the wrong things to do, because the people that died were not people that were old, were people that were badly affected by the disease. And who were the people that were badly affected by the disease were normally male patients. And that, again, that is not something that was new to us, something that came from all the documentation from China, then the documents from Italy showed exactly the same, great preponderance of men. And
Yes.
that's one of the very, 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 very first things that we have seen as well. So I started looking into that. So I will expand later. So
Okay.
about triage is not something that was not our adoption. Westminster Foundation Trust was some early trends about trying to limit the level of care, but was not our view. We actually reversed and we opposed actually to the triage system. Unfortunately, few patients at the very beginning seems like were affected by this, and proved that we were right at saying we must treat people that are 80 plus, doesn't matter age, because actually, if you are a lady, regardless of your age, you become unwell, you can get through the process. The problem, but I can expand into all of that. I'm sorry, but I have to say this because triage is a bad word and people must not triage. Need to patients individually and manage as they are, because they proved all the publications that triaging was the wrong things to do.
Yes, and I completely agree with you. Be treating each patient as an individual.
Correct.
And I certainly don't support using any of the more directive criteria. But of course, we have to take frailty, for example, into account. Absolutely. Thank you.
Okay. Yeah.
I agree with you. And I did see your email. Thank you. Yeah, I'm not going to go into this because I know you probably are, Marcela. But this is the CPAP that we were using on our wards. We have also purchased these kits, which are single patient use disposable kits, because we were worried we would run out of CPAP machines, and these plug directly into the oxygen supply. However, they do use a lot of oxygen, up to 140 litres. And we were starting our patients on a PEEP of 5 to 10 centimetres, up titrating in some cases up to 15, although I know there have been some problems experienced with pneumomediastinum on ITU subsequent to this. And just to note that this is an aerosol generating procedure, so it's important to ensure that at the bare minimum these patients are cared for inside rooms with the appropriate PPE. And anecdotally, we have seen our patients benefit from regular proning, so 2 hours twice a day, for example. This has had a significant impact on these patients that have survived. So I'm going to leave it at that. Any questions at all?
So Thank you, Veronica. If I may just jump in and just ask one question.
Of course.
So thank you very much for the talk. Actually, I had lots of questions in my mind, but you answered them as you were going through your presentation. So are you currently now doing, are you classifying your patient or doing any advanced decision whether they're going to go to ICU on admission? Do you make that directly?
Certainly not with any sort of scoring criteria. No, this is on a personal basis, and personal views should also be taken into account. So patients' preference is also very important here, as well as the family's opinion. But it certainly is a case-by-case decision, and I'm certainly not advocating any of these scoring systems. Okay.
But are you meant to make that decision like early on in the management of the patient?
Yes, in order to, so that we can understand expectations, I think it's important to clarify that with the patient and their family early on in their admission, so that we are all working on the same page. And I think that decisions in respect to COVID infection as opposed to other conditions, escalation decisions have been very different. As we know that patients do badly in general if they have COVID infection compared to non-COVID infection.
Thank you very much.
Thank you.
Thank you, Dr. Veronica. I had one question for you, is that in the first case, the patient had very striking changes on the chest x-ray. And my question really is regarding use of CTPA. In some centers, if they have if they have chest x-ray findings which are consistent with COVID, they don't routinely perform CTPA. What's your sort of practice?
So we know that they get high D dimers with COVID, of course, and we know they're going to be hypoxic. I think that a strategy, although there's no evidence behind it, has been to do serial D dimer monitoring, for example, after a 48-hour period to see if that has changed. And if the D dimer appears to be going up, in some cases we have gone on to do a CTPA. But oftentimes they will develop the pulmonary embolus during the admission, either to ITU or to hospital.
I will pick up on that when I go through the traffic light system that we developed for our trust. So it was a lot of background work in the background to identify that as well, and guide us in the management.
Great. Okay. Any other questions? Well, thank you very much, Dr. Veronica Smith. That was a fantastic presentation. If you could stop sharing your screen for a moment.
Oh, yes. Yeah. Thank you very much, everyone.
Okay.
Thank you, really lovely. Nice to meet
you. Thank you, Dr. Veronica, and we really appreciate it. Thank you for your time.
Thank you, bye.
Thanks a lot.
Okay, so I'd like to welcome Dr. Marcela, who you have all seen already this evening. She's a consultant in intensive care medicine working at the Chelsea and Westminster Hospital. And she will be giving us some insights today about her experience and sharing some of her experiences regarding the critical care management patients with COVID. Thank you, Dr. Marcela.
So hello, thank you. And so basically, somehow, as I said before, this experience with COVID is quite close to my heart, because when everything started, the first thing that I realized that we didn't know anything about it. So it's a disease that we have to learn while we were managing patients. And as a frontline physician, as most of us, the only thing that we think of is what we can do to stop the disease. You know, we cannot be researchers because we need to treat patients. So we need to understand the disease or the physiology or pathophysiology to see what we can do to stop the progression of disease. So since the very first report, I started looking into the literature that was coming through, and straight away we noticed that male patients, people that were admitted to hospital, were the large number of them were male patients. So clearly there was some kind of preference in gender. That's quite interesting because you don't have a virus that is so clever that is, I will affect women or will affect male and not female individuals. So that's something that was bothering me because we started seeing across the globe the pattern. You got the virus and you were a man, then the chances end up in hospital with a severe pneumonia and your mortality would be higher. Why that? The other thing that we noticed, pure physiology, that up in intensive care were patients that got very high ventilatory compliance. Once the tube was in, it was very easy to ventilate them. And patients that end up on mechanical ventilation got very, very high mortality. And these two things were kind of difficult to put together because, as we know as physicians and intensivists, we know if you got very high compliance, it's a question of time before you get better. So why patients with very high compliance end up dying on the ventilator? The other thing that we notice is the patient comes with gastroenteritis or some degree of inflammation. That was very common to all of us when we were receiving this type of patients in hospital. As I said, the mortality reported out there was extremely high. By the end of April, we got mortality, of 67% in Washington, 51% in the UK, and that was constant. So, we cannot accept that someone will die. What's the point to come to hospital if you throw a coin and say, live or die? So must be something. So I started looking into detail what was out there. And so the three things that was very clear from the very beginning, older, multi-organ failure, and high D-dimer. So in our head, in my head, age, there is nothing we can do about it. Multi-organ failure, that is the response to a disease. So the only thing was the high D-dimer. High D-dimer is telling me that something very, very acute is going on, something that I can actually manage, like a thromboembolic event. So started seeing the number of cases coming through more and more. So this was getting very serious. So I started buying more equipment, trying to do connections with the different dashboards, make sure that the oxygen supply, the liquid oxygen, the tank was full. So we calculated the amount of oxygen that we will need to ventilate 250 patients in our organization. And all this work based on the information that we were receiving globally. The other thing that from the very beginning that was bothering was the high D-dimer and all these post-mortem examinations. So we're coming from China, from Italy, from Spain. So we were seeing post-mortem examination showing thrombosis, microthromboembolic events, microthrombi, thrombus, and so on and so forth. So in my head this is the cause of death. People are dying in hospital because of big, massive pulmonary embolism. So that's something that we can stop. We don't need to go and do postmortems. And that is what we started looking into our data. More data kept coming, as you can see, postmortem examination. And so what we did, because we got an electronic medical record in our organization, we started looking at the physiology of our patients at the point of entry into hospital. So while we clinicians were the front end, we got 25 people from the informatics team and the IT department in the back end crunching the information that we were getting from our monitors, trying to find a signal to detect patients at risk of thromboembolic events, to detect patients at risk of cytokine storms, because as you remember, a lot of people were talking about this super inflammation, that people were dying of it. And it's true, we got some few patients and they died, but what we noticed that we could control was the thromboembolic event. So we wanted to identify, a signal. And so we actually looked into all the physiological parameters initially until we found that the CRP more than 200 or D-dimer more than 1000 could predict the risk of thromboembolic events. So we started characterizing the patients. And that's when we got the traffic light. There is a dashboard that updates in real time every 10 minutes the risk of our patients of developing thromboembolic events. So basically we knew patients that were at medium, no risk, medium risk, high risk, and suspected. Straight away at 10 minutes, you know, of coming into hospital. And why was that so important for us? Because that could help us to introduce treatment. What does it mean? Treatment. Yeah, people were thinking about the vaccine, people were thinking about treating the virus. You know, in my head as a simple physician was, we have to manage things that we can treat, you know, while there is an investment in the rest. So we're starting to increase the dose of Clexane. We got hematologists involved, and we started sharing WhatsApp groups and across the Northwest London and with my colleagues at West Middlesex. And we increased the dose of Clexane from 40 milligrams once a day to 40 milligram BD for every single patient that got the CRP more than 200 or the D-dimer more than 1,000. If the patient got CRP more than 250 or D-dimer more than 3,000, that were our patients at high risk. And that when we said, okay, this patient will need a CT scan. So a CTPA. So the CTPA allow us to define if there was a thrombus or not. There was present a pulmonary embolism or venous thrombosis, patient was started. And you can see here quite nicely in this little chart, you know, this is already in the public domain, that by age, you know, you can see straight away female patients that were discharged, see, in here, and male patients. And when you look at people that die, you know, so you can clearly see very nicely, you know, that the trend were about male. Male tend, if they end up in hospital, they tend to do badly. So large, big concern for us. So we look at the analysis of gender by age. And you can see here, regardless of age, the people that got bad luck were male patients. So straight away, and that was bothering me, and that's when I actually started working with Professor Shovlin from Imperial College, because she is the lead for the genomic project. And I rang and I said, look, I got a problem here. I don't think that this virus is that intelligent. We know that the AC2 protein is a problem because in China, they already were looking into that. There is a lot of people talking about resistant. The virus is resistant, and there is some mutations in the protein on this particular receptor. And I said, but has to be something because the receptor, male and female, so it's not gender specific. We all got this receptor. Why male patients get more affected than women? And that is when she got into the genomic bank and downloaded all the images, and we ran over weekend a big analysis and identify actually that the cluster for this gene of the AC2 protein is in the X chromosome. And of course, if you got the abnormal variant of this particular protein or the wrong cluster, that actually gets the ROS and also the endothelial growth factor, you know, people will manifest with vascular changes that will lead to cytokine storm pictures. And if you are a man, you got only one X chromosome. So it makes sense. If you get unwell and you got the abnormal variants of this protein or this cluster, you will be sicker because you don't have a way to compensate it. So all is something that is working in the background, that people that, you know, can actually do the research because we need to look after patients. We activated a kind of engineering or kind of work while we carry on looking after patients. With a flag system, it's quite important. What we noticed is that we could discriminate patients, you know, that were flagging for thromboembolic events, patients with pulmonary, with ARDS type picture. And you can see there were not many patients with cytokine storm. So the killer was the clot. And believe me, all of us can treat clot. We don't need to be fancy. We don't need. So that the key was keep the patient hydrated, while most of people, what we were doing at the beginning, keeping patients dry, because we were told that we need to keep the patient crispy. So you come a patient with very high temperature that come with very high risk of thromboembolic events, we dehydrate them, put positive pressure on the chest, and surprise, surprise, they do badly. So we we're doing a bit of reverse engineering here. We went to basics. And we managed to, somehow, we got more than 1,000 patients admitted in our organization, and we got a mortality of basically post-introduction of this system of 22%. So we went from pre-traffic light to post-traffic light. Of course, there are other factors that influence the management of our patients. I think that's what I wanted to share with all of you, is that simple things like a thromboembolic event, if we manage them early and we actually hydrate our patients and control, support them while we get the virus coming down or the viremia, we can get them through, because it's a long process. People, there are two kind of group of patients, the one that needs few days, 3 to 5 days and get better, and the one that needs prolonged mechanical ventilation. And I think that you can see how inflamed they are and how we discriminate. The people with highest mortality tend to be normally, as I said, male and are more inflamed. And this is quite important. So if there is a background of inflammation, but the inflammation is the driver, but it's the cytokine storm or that causes like this shock, like we got vasoplegic shock. Probably you remember, probably you see this type of patients from the past when used to come with severe pneumonia, patients with severe pancreatitis that were inflamed, systemic vascular resistance of 300, 400, and you give fluids and you couldn't make the patients better. And you had to put noradrenaline and you put your vasopressin, and and you could see that your patient was, dying. So we try to identify early the patients that were at risk of vasoplegic shock. And that's when we started looking at the ferritin. So any ferritin, again, about 1,000 was our initial trigger. More than 3,000, patients need to be close management and try to refer to intensive care, and early intervention like introduction of terlipressin, antioxidants, and so on and so forth. So somehow we just done what I tend to tell my junior doctors is, try to support the patient, try to reach a balance where you can sit and wait for the disease to dictate the pathway. And sometimes patient was kind of the key for us. And let me just show you, this is still something that we are now, that we are behind. Also, the first search is, for the first group of patients kind of gone, we started looking into the ICU pattern. Because I can tell you from the patient's perspective, in hospital, from emergency department, medical wards, until the point that they come to ICU. But into ICU, why? Some patients improve very quickly and some patients needed a long time. Yes, this is kind of descriptive analysis. Perhaps all of you have seen, there's a lot of publication about descriptive mortality. I'm not interested in that. We are not interested in that. We're trying to find a pattern that will allow us to identify something that we can do to reverse the pathways. And you can see that looking at simple things, when the people look at the PIP and the PF ratio, and you can see there are different patterns. There is not something very distinctive, but there is a cutoff between patients, okay? So if you look into here, there is a before and an after. When you look into in the x-axis, you can see there is a variation in number of days. This patient, how far away? This patient, how close to the day of admission. And this is the kind of analysis that I'm interested in, because when I understand this, then we can identify, you know, what this, for instance, these 4 patients behave like this, or this patient behave like that. So
Veronica, might interrupt you just for the sake of time. I might ask you to try and cover the last 2 slides as well, because we're kind of running short of time.
Yeah, sorry. So basically what I'm trying to say is, or try to share with you is, you know, is nothing fancy, is how we try to understand these patients and how we were trying to do things to keep them alive until was a reverse on their medical condition. And the change of the medical condition was not because of us. I think it's because there was a switch. And we don't know what made people switch early or late. So the only thing from our experience, what we learn is don't give up. Just keep supporting, maintain the nutritional support, carry on with the weaning, and if the patient becomes unstable, trying to find to maintain the cardiovascular system by early using, you know, fluid resuscitation and vasopressors when required. Passive leg raising helped us a lot because it was quite dynamic, so we could adjust the fluid intake according to the individual needs, not because it says in here or says in there, because the response varies from one patient to another. So my take-home message from this is we learned a lot. Sadly, we lost patients because we talk about excess mortality. I think that there is more to learn. We are reviewing every single case that die in our trust, and that include West Middlesex and Chelwest and Westminster, because it must be something in there that we can learn to prevent this excess of death if we get a new surge. And yes, we can treat things that can be treated. You know, we are waiting for the cure, if there is a cure. But in the meantime, as acute physicians, we're trying to find a way to, you know, to be confident with what we do. So this is probably, I will stop in here because I can keep talking. And if you have any questions, just ask me, because I'm happy to share anything that you think that would be useful.
That's very good. Thank you very much, Veronica. I think it was a very interesting points that you raised about the use of biomarkers to kind of stratify your patients and guide your management, whether it be in the anticoagulation era or the ICU therapy, intensive care. So I think, I'm sure there's a couple of questions to be given, but I think for the sake of time, I would like to introduce Abby maybe, and maybe leave the questions for the end of the talk, if that's okay. I have a couple of burning questions myself, but I think if Abby is around, I'm not sure if she's already with us. She will be giving a talk on the therapeutics in COVID. If Abby isn't ready yet, maybe we can leave the floor for a question or two to Marcela. Okay, great. So Abby is here. So I will leave the mic with Abby for the meantime. And thank you very much, Marcela, again, for the very wealthy talk.
Hi there. Hopefully you can hear me, Hatem. Just checking.
Yeah, clearly. Thank you very much.
Thank you, everyone. Thank you, Hatem and Ibrahim from Sudan, who've organized this and invited me in. And thank you to my colleagues, Veronica and Marcela, for their excellent talks. I hope what I can do in the next 10 minutes or so, I know there are more interesting topics to cover, to kind of be brief about the trials and therapy in COVID-19, because I know a lot has emerged. And this is just to kind of give us a 10 minutes of what do we know about trials and what we should be looking for, and what trials should we be aiming to be in, or what therapies should we be aiming to be in. So hopefully, sorry, I think I'm having, let me just see, I'll aim to look at the trials, the outcomes, and what should we be aiming for. And in summary, is just to kind of start off by saying there's been a lot of intense, I think this has been a historic period where that many trials have been launched. Over 500 clinical trials have been registered. Most of them, actually, interestingly, are randomized control trial, and I don't think any historic time has ever had that many trials registered and conducted. We've also had some observational studies, and a lot of them have come from international international collaborating studies as well as the WHO. Some of the drugs looked into some of the trials have looked into new drugs, some of the trials have looked into kind of old drugs and whether we should be stopping them. And obviously there is emerging therapy such as plasma therapy, stem cells, and vaccines. So I guess this is a very good demonstration of how many trials are out there and what drugs are they looking at. This is coming from the Lancet, and as you can see, the amount of interaction of trials versus other trials versus standard care and combination therapy. And as yet, we don't really have one particular drug or one particular therapy that's going to guide us, but we're all in hope that there will be something we can find or utilize in the period while vaccination may be hopefully the forward future for kind of treatment of COVID-19 or preventing COVID-19. This drug has had a lot of essentially a lot of kind of people being interested in it. Is remdesivir. Remdesivir is actually a drug that first came into light in the Ebola and the MERS pandemics. Essentially is a nucleoside analog prodrug that inhibits the COVID from reproducing, and it was tested in animal models previously. So essentially a lot of studies have looked into this, and I'm just going to go through the biggest trial that's looked into this with the data we have, just so I know that this drug is currently in use in compassionate for compassionate reasons in some places, and that might be the case in Sudan as well. So essentially the trial was a randomized double-blinded placebo-controlled study. It was multi-trial, multi-central trial. It involved recruiting adults over the age of 18 who were admitted to hospital with a coronavirus infection, who actually have had symptoms up to 12 days at that point, and had a saturation of less than 94% on room air, and had a confirmation of the diagnosis of pneumonia. So you needed to have some kind of moderate criteria for COVID and needed admission to be on this drug. The use of other drugs, such as interferon corticosteroids and other kind of retroviral drugs, was also included in this study. And essentially this was an intention to treat study. The primary endpoint was to see if there was any clinical improvement, and obviously mortality would have been one of the other factors that would have been measured. Essentially 237 patients were enrolled. So there was the placebo, who were the standard of care patients, versus patients who received the drug. And interestingly, what was found in all essence is that there was no associated difference in the time in clinical improvement. But though this wasn't statistically significant, those receiving remdesivir had a numerically faster time to clinical improvement. And this has created the whole kind of hoo-ha about use of remdesivir, and particularly in the United States. And I don't know if my colleagues from Chelsea and Westminster are around to share their thoughts later on in the discussion. Overall, it did show that actually the viral load and the viral copying wasn't much different in the placebo or the control when it was compared from the time of the start of the study. But overall, the number of days to getting better statistically wasn't significant, but some patients got better quicker. There were limitations of this study. A few patients were on ECMO and mechanical ventilators at the time. There was a question about the pharmacokinetics. So patients who are severely ill, they will have very altered pharmacokinetics. So it means the absorption of the drug would differ. Different doses may be required for those patients. What was clearly seen that many patients, I think up to 66%, reported adverse GI events, such as diarrhea and cramps, as this drug was given to them. And obviously this may be an initial study to kind of look at whether higher doses are required, whether this would be used with other antiretroviral drugs or other drugs such as the kind of interleukin families, to see if there is any improvement in symptoms and mortality in these patients, and whether we should start them in patients who are less sicker. So I think there is a lot to learn, but this is the first study that had shown there was some benefit in reduction of days in hospital in these patients. I'll move on to immunomodulation and what we know. So as you know, one of the aspects of COVID is the cytokine storm that we see, which is related to kind of the release of all these interleukins. And essentially that leads to an inflammatory process that causes capillary alveolar leakage. And essentially what we find on on CTs and chest x-rays, which is this horrible appearance of ARDS on the chest, which leads to mortality most of the cases. So immunomodulation is being looked at, and this is just a diagram to show you how complicated this is and how complicated it is when it comes to use of other drugs that have been mentioned. And I'll briefly mention the ACE inhibitor story later on in terms of what we know so far. But it's a very complicated pathway, and if we can inhibit some of these processes, maybe we can dampen the systemic process that occurs in the lungs. This is a kind of a reported study that I did find regarding using IL-1. It's probably the biggest study there is, though it was retrospective. It looked at, again, it kind of in recruiting adults who had COVID-19 with severe ARDS, who've had a hyperinflammation diagnosis. Some of these patients were managed with hydroxychloroquine at the time, as well as other drugs, so it wasn't just the IL-1 inhibitor. And what they found that in these patients, there was some improvement with giving them this drug. Overall, what you could see, the patients who received it were the ones in red, and high dose IL-1 essentially increased survival, but also reduced the need for mechanical ventilation. So there was a small retrospective study, some positive data came out of it. But again, this is limited. It may suggest there is something positive, but this was used in the combination of other drugs. So it's very difficult to tell whether these patients were going to get better by themselves or actually this drug is effective. And again, this wasn't in a randomized controlled trial. So the biggest story is probably being the hydroxychloroquine story, and whether its use alone or with macrolide could be something positive. As you know, probably very recently, this was published, and a lot of questionable debates have been had as to the data and where the data came from and whether the registry was analyzed appropriately. And eventually this paper has now been retracted. But I just wanted to mention some points and mention about possibly the future of where this drug could go. So essentially the study was a multinational registry analysis of hydroxychloroquine with or without the use of macrolides. Over 96,000 patients were recruited from 6 continents, so it was a huge study. But in essence, it showed that they were unable to confirm the benefit of hydroxychloroquine with the use of macrolide in hospitals for patients with COVID-19. And if we look at the data, essentially, it didn't demonstrate any significant benefits of the use of this drug also with post-exposure prophylaxis in other studies that have utilized this. So from there, unfortunately, the use of hydroxychloroquine has actually been abandoned by the WHO, and we'll come to it. But other studies currently are actually also who've looked at hydroxychloroquine, including the recovery study, which we're part of at Chelsea Westminster, shown there's no clinical benefits of using hydroxychloroquine in patients with COVID-19 in hospital. So the recovery trial, given that I've mentioned it, I thought I'd mention it very quickly here. This is probably one of the largest trials that are going on globally. It's recruiting many patients from all across the world, including the UK. And it's looking at use of kind of antiretrovirals, the use of hydroxychloroquine. The recruitment has closed, and I think evidence has been drawn that it's probably really not effective. And the use of using convalescent plasma and so on. But as yet, I don't think we have very much data to suggest any of these drugs are useful for the management of COVID-19. I know in what I say kind of in the Middle East, hydroxychloroquine is highly available, and therefore people have been using it to prevent infection. And just to say that absolutely there is no evidence is yet to show that this is going to have any favorable outcomes. What I came across was a meta-analysis which I thought clearly demonstrated the hydroxychloroquine story and the mortality rate. And what you can see actually that kind of this meta-analysis showed that compared to kind of standard regimen, there was no difference in the mortality rate between hydroxychloroquine group and those who had standard treatment. So actually there was no benefit of using hydroxychloroquine. And when we looked closer, we found that actually some patients with kind of comparative other randomized data showed that there was 2.5 times higher mortality in those who received hydroxychloroquine as well as azithromycin. And I guess that relates to the story of arrhythmia, this cause being arrhythmogenic. And the overall mortality, when we looked at pooled data, it showed that there was an increase in overall mortality in patients who'd received hydroxychloroquine, and certainly there was more adverse events reported from these studies. So overall, if we kind of looked at this in a meta-analysis way, again, hydroxychloroquine doesn't win any favors, and I don't think there is yet any role for it on its own or with the mentioned drug so far, azithromycin or a macrolide for management or prevention of COVID-19. So again, as you know, these are kind of, there are lots of limitations to all of these studies because some of them could be observational. The randomized control trials have been smaller numbers, and there is a high selection of bias and high heterogeneity in all of these studies. So I think we're yet to come to a place where we could definitely draw the line, but the favoritism is not to use this drug kind of on a routine basis for management of people who are COVID-19. And as I've mentioned, the WHO has suspended its use for safety concerns. So moving on from this is I wanted to briefly mention using of plasma therapy. This is something that's been highly advocated where possible. Patients who've had COVID-19 kind of donate their blood, and plasma is withdrawn from that. And there has been some trials with regards to this. So far, the biggest study has been kind of a single arm study looking at a total of, not many patients, actually 32 participants that were intervened. And the data didn't really show anything very much. It showed low certainty of effectiveness in the use of this. However, it was mainly measuring safety outcomes, but yet we don't know whether this will be preventative in patients who haven't had COVID-19, or can it be used for the treatment of patients who have COVID-19? There are at the moment biggest studies going on. There are about 47 ongoing studies, and of which 22 are randomized control trials. So I think we will learn more about this in the future, but yet it's not a therapy, it's more in the trial phase. This has probably had a lot of kind of media press about the use of ACE in COVID-19, and some patients unfortunately were told to stop their drug therapy during that time. I mean, from a cardiac perspective and from all of what we've seen with COVID, it affects men. It tends to be in patients who are hypertensive and have high cardiovascular risk factors. They seem to be the people who are unfortunately at risk and have a higher morbidity and mortality associated with it. What we do know that if this is a population of patients, we see that they are more likely to be on these drugs when they are admitted into ITU or to hospitals for management of their COVID. What we also know is that patients who've had, who get COVID, there is something to do with the binding of the angiotensin converting enzyme that's expressed on the lungs that's probably likely to be the source of kind of the infection of the epithelial cells. But so far the data stands that there has not been any randomized control trials to say that these drugs should be stopped. There is no evidence to support that basically these patients should stop the therapy, and if anything, controlling high blood pressure and cardiovascular risk factors would lead to improved outcomes. So I think from all European societies of cardiology and international societies of cardiology, the management remains that these patients should remain on their drugs, and certainly these patients shouldn't stop their medications to prevent COVID-19 because there's no evidence for it. Where are we with vaccines, which I'm sure you know, and I won't dwell too much time on it, is that there are many trials on the way at the moment. We have seen some positive results from the Oxford study that's undergoing at the moment, but a race for a vaccine continues. And, you know, the vaccine story is very interesting because I came across this study about the kind of the seroprevalence of kind of producing antibodies in populations who've had COVID. And essentially the idea of getting a vaccine is to have an antibody that would be protective against COVID. This is from WHO, and basically it showed that patients who've had COVID, only about something like around 3% of them would have an antibody or had an antibody that would be likely to be protective. And what that suggests is, unfortunately, though a vaccine may be developed, what we're learning at the moment is that not everybody mounts an immune response enough to create an antibody that may be protective. So I think that story will carry on for a while before we know how vaccines will develop, if this is what we are seeing from people who've been infected with this condition. I'm not going to dwell too far on coagulopathy, but as you know, that coagulopathy is a big complications of patients who have COVID. I think Marcela briefly may have mentioned it, so did Veronica, that we see a high population of patients who came in with COVID-19 and had thrombotic events as a result of it, and predominantly pulmonary emboli was the largest kind of complication that we saw. This is just a diagram that I've pulled from the ESC. I think a lot of trials have been done, a lot of data collection has been done. In essence, in all cases, heparinizing the patients or putting the patients on some sort of anticoagulation with low molecular heparin is advised unless contraindicated, and I'm sure Marcela can add further to it, but all studies and trials head towards the same directions, that we should be thinking about anticoagulating these patients right from the outset of admission, particularly if they have high D-dimer levels or they have high other risk factors that we see when we admit them in. So in conclusion, while I've kind of mentioned that there are 500 studies, I haven't summarized every study, but what I've done is gone through the biggest ones that are available to us and the data that's available. I think there is the use of kind of remdesivir to be used outside a trial for compassionate use. And I know at the moment, many of kind of the African countries and many of the countries in the Middle East will be looking into using remdesivir. And maybe as we collect more data, we will understand more about this drug, and maybe there is something about this drug that would help kind of bridge us to a vaccine if a vaccine should be ever developed. I think there is still a lot to learn, and I think different populations will behave differently. So I think we should be mindful of that when we treat our patients, and every patient should be treated as an individual rather than part of a study or a trial. And I'll end on that point. Thank you.
Thank you very much, Dr. Abi. That was a fantastic overview of a lot of clinical trials, a lot of data, and it was a fantastic summary. Do we have any questions from the panel or from the audience?
Not really at the moment, I think, and I think for just because we're a little bit running behind the time, I think we can move to our next speaker, Dr. Linah Suleiman, who will be presenting clinical emergency assessment of COVID-19 patient. And I think we will be back again to you, Dr. Abi. I think with a few questions from one of the colleague. He's joining us last week, Dr. Saeed Ahmed. I think he wants to ask about the clinical trials. So we will be back again to you, Dr. Saeed, and over to you, Dr. Linah, sorry.
Thank you. Can you hear me well?
Yes, we can hear you, yes.
Good. I'm just trying to share my screen. Apologies.
Are you okay with Dr. Linah, or shall we move to our next speaker and then come back again to you while you prepare your slide?
That would be great.
Okay, right. I think we got Dr. Emmanuel Ako. He will go in to talk about the resuscitation in COVID-19 patient. Dr. Emmanuel, can you hear me? I think you need to unmute your
yes,
mic.
I can hear you.
Oh, good, good. That's good. Right.
Perfect.
So I think might be better to give your talk first, and then we will go back again to Dr. Linah.
Okay.
To deliver her talk. Yeah.
Okay. I'll just bring up.
Okay, it's over to you.
I'll just close some of these down. Okay, can you see my screen?
No, we can't see your screen.
You can't see my screen. Okay.
If you can
Yeah.
select share screen and yeah, perfect.
Still not sharing. Okay. I'm not sure why my screen is not sharing with you. Is there anyone else who's able to go? Just so
I think while we are waiting to sort of this little bit technical issue, I think we can, Dr. Saeed Ahmed, I think we got him with us now. Dr. Ahmed, can you hear me?
just check. Can you see my screen? Just check.
Yes, we can. Yeah,
Okay.
yeah, we can see on the screen. Yes.
Okay, I'm sorry. Sorry for that hiccup. I'll just quickly, I'll try and make up some time.
That's fine. Then go ahead.
So thank you very much for the invitation to talk. My presentation is on the resuscitation of the COVID patient. As you've heard throughout the earlier talks, it's a very contagious disease, and also the mortality is actually quite high, particularly in the older age group. And I think what I would urge my colleagues around the world to consider is that when you see a patient with COVID, you should assess what your escalation of treatment plan is. And is that, are you escalating all the way to intensive care? And are they suitable for a resuscitation order if they were to succumb to the virus? So hopefully my talk will briefly cover on the absolute need to reduce the provider, so the healthcare worker, from exposure to COVID-19, and how to provide oxygenation and ventilation with reducing the aerosolization exposure to the healthcare professional, and also to consider whether it's appropriate for starting resuscitation in the first place, and also whether we should continue it, and then a little bit about the guidelines on patients that go into cardiac arrest. So the unique challenge that COVID provides to healthcare workers, where their instinctive urge is to provide assistance, is that it is a very contagious virus. And so your personality or your personal safety is essential. And before we start any resuscitation, we also have to look around for safety. And in this case, the virus affecting the healthcare provider is a key one. So with the COVID-19 virus and CPR being an aerosolized generating procedure has to be at the forefront of our minds in all patients that we admit with possibilities of this condition. You may have heard throughout personal protective equipment, or PPE, and the media coverage with regards to whether healthcare professionals have access to this, or whether hospitals have provision for their healthcare. This is just a visual guide, which you can see with the diagram on the left. You have, if you're in contact with someone who's suspected of COVID-19, you should at least wear a mask. And this can be a surgical mask with a liquid resistant gown, aprons. Ideally, you should have your arms and hair covered. And if you're then going to take part in an aerosol generalizing procedure, and this includes CPR or intubation, you need to have eye protective gear. You need to have at least an FFP2 or 3 respirator, a long sleeve gown, and gloves. It's also important, always remember to wash your hands before and after you wear the protective gear. So the advice for patients in the community, if you were to see someone who's gone into cardiac arrest, the first thing to do is to dial the emergency number and get an automatic defibrillator. You should cover your own mouth first of all, and then the nose and mouth of the person who you would be resuscitating, and you perform only hands-on CPR as the routine 100 to 120 compressions per minute, and then you apply the defibrillator. In the hospital, the slight change to your basic life support and the advanced life support is, first of all, the safety is you have to wear the PPE. So if you don't have a PPE and someone has confirmed COVID, you really should not resuscitate until you yourself are protected. So you've done your personal protective equipment, you limit the personnel to only the essential team required in the room, and then you go down your usual algorithm. So you confirm that the patient is unresponsive by shaking. In the basic algorithm, you used to listen and feel for breath sounds. That's been taken out because you want to avoid proximity to the breaths or airways, and then you go about your chest compressions in the same manner that you will do. So you no longer listen or feel for breath sound to diagnose the arrest. You just feel a pulse on the carotid for 10 seconds and then commence CPR if you've confirmed arrest in the normal protocolized way. So this is a hospital simulation of a CPR. You can see there are minimal number of participants in the room. Everyone has full PPE kits with the visors, the mask, the hats, the long gowns and the gloves. Anesthetist at the head, someone documenting and making sure that the right medications and protocols are formed. And chest, you only do chest compressions when everyone in the room has a level 3 PPE. So you do not start chest compression until everyone is gowned, because you put everyone at risk. So in the hospital, we use the same. So you go through your normal sequence of 30 compressions to 2 breaths. And again, you use a bag mask valve, which has a fitted filter attached to it, and you create a tight seal. And then when you get your intubation, you can do your continuous chest compressions. And then as usual, you go through your 4 H's and your 4 T's as part of your algorithm, and then check if you've got an ITU bed available very early on, because this will have to be the end point in terms of getting your patient to. As a cardiologist, in terms of the cath lab, we treat everyone as if they've got COVID-19. And so what that means is everyone has a full PPE kit. And again, as we've been through before, the visors, the masks, and we consider the full PPE kit for everyone who comes in with an ST elevation, myocardial infarction, or those who have a high-risk NSTEMI case. This is our gown we wear. So again, repeating what I've said, the visors, the mask, the respirators, and the gloves. And this is very important. So it's very important that you don your gown, clean your hands, don your gown, and particularly when you're taking it off, the doffing is the important bit, because that's when you can contaminate yourself. So it's very good to do that in pairs and to practice. So in the cath lab, we make sure our patient has a mask to prevent the spread of any aerosolization. We also wear a mask. And it is very important that we practice this, because the first time you do it, you're not used to having to wear PPE. So it's very important you do regular simulation type practice, because practice will be the key to success for you to get quick. Also update your local protocols with regards to how CPR is done and the need to wearing your PPE kit, and education through videos, webinars such as this, and podcasts are very important. So that's just a quick summary of resuscitation. Happy to take any questions, and hope I've got you some time back.
Thank you very much, Dr. Ako. Thank you for going through all of those points about resuscitation in COVID. I had one question about in the cath lab. So does everybody in the cath lab wear full PPE in terms of the full FFP3?
Yes.
Yes, okay.
Yes, so everyone in the cath lab, so all patients are treated as COVID positive. And the reason for that is really we are trying to minimize healthcare workers from getting infected. We've had situations where we've done a rapid COVID swab, which has come back negative, and then subsequently the PCR is positive. We've had also vice versa, where the rapid one is positive and the lab is negative. So there is some reduced sensitivities of the test. So we have to protect healthcare workers and prevent the spread between patients. So we all wear full PPE kits.
Okay. Yes, in our centre, we have the first operator, the second operator, and one scrub nurse who wears full PPE, full FFP3, but everyone else wears the standard PPE. Okay. So Dr. Saeed, I think you had a question.
Yeah, assalamu alaikum everyone. Dr. Emmanuel is doing what you do in the cath lab, a diagnostic or interventional PCI, an AGP?
Yes, so we're not doing any diagnostic procedures in the cath lab. They're all graded as being emergency or urgent outpatient work, except for patients who've got significant valve disease and need to have an angiogram procedure before it. But these are all patients who are deemed to be emergency or high risk and so by definition are at high risk of going off in terms of having a cardiac arrest.
Right, so is it in anticipation of a cardiac arrest you
It is, absolutely, yes.
Procedure is not AGP, but the subsequent procedure is. That's
so
what I'm clarifying.
It's in anticipation of a cardiac arrest, that's correct.
Okay, fair enough.
So there is guidance from the BCS and the British Cardiovascular Intervention Society and the British Heart Rhythm Society regarding what's an aerosol generating procedure in cardiology. And if you have a primary PCI, would classify as a aerosol generating procedure, whereas PCI for stable ACS is not. So there is a distinction.
Yes, that's true. That's true. I think it's the risk of someone having an arrest, and so by definition, a STEMI and a high risk ACS. That's correct.
Okay.
Can I just ask a quick question, if that's okay? Thank you much for the presentation, Emmanuel. So when you talk about the PPE for cardiac arrest situation for COVID patient, I guess you're talking about people who are confirmed to be COVID and people who are suspected to be COVID as well. The precautions are the same. Is that right?
Yes, that's correct. So if you have a high suspicion or someone is confirmed, it's a full PPE kit for the resuscitation team because it's aerosol generating.
May I ask, I mean, do you think that would put a significant delay on patients' resuscitation in case if there's no sufficient staffing in PPE at that time? It might be applicable to certain places that you might not have enough staff in PPE ready to go for the CPR, but a significant delay, because my understanding that PPE take a while to put it on and have the gown and everything. So what's your take on that?
And that's my exact point, why I said there's the absolute need to practice. And so this can be, so for example, in my institution, we had a kit for practicing. And so you don't have to waste PPE kit for the simulation runs. And so all the team had to practice this over and over to get quicker. Now, putting on the FFP3 mask and the visor is quite important, but the more you practice, the quicker you are at doing it. And I think the risk is really balancing between the risk of getting infected as a healthcare professional and not being able to provide that care for the rest of your patients versus running in without any protective gear. And I think even our Resuscitation Council advised that if you don't have the full PPE kit, you shouldn't start CPR. And I think bodies around the world should almost put similar type of guidelines for their healthcare professionals. So it takes it out of the hands of the healthcare professional, but it's a body that's recommended that because it's a highly contagious virus.
Thank you very much.
Just to add to that, so in our centre, the primary operator and the second operator and one scrub nurse are wearing full PPE. So if there was a cardiac arrest, everybody who's not wearing full PPE would leave the cath lab, and we use a separate cath lab, a dirty cath lab, and the CPR can be commenced. So yes, there is a delay, but you're minimizing that delay because when the other team who are donning their PPE, that can be done outside the cath lab.
Yeah, I think that the difficulties are the ward-based patients where not everyone always has the full PPE ready to go. But the arrest team coming in should make sure that there is that they're completely protected.
Okay.
Right. So,
thank you very much, Dr. Emmanuel. And now I would like to introduce our next speaker, Dr. Linah Suleiman. She is going to talk about emergency assessment and management of COVID-19. I think she had two interesting case presentation. Over to you, Dr. Linah.
So I'm going to touch fairly briefly on the emergency assessment and management of COVID from the front door into the ward, and then I'll speak about two interesting cases. So moving on to the second slide, please. This is the agenda for the session. So triage and initial assessment, venous thrombophlebitis, entry
Dr. Suleiman,
case presentations. And
sorry to interrupt you, Dr. Suleiman. We can't quite hear you. Would it be possible to perhaps position it a bit closer so we can hear? We can't actually hear it very clearly.
Okay.
Yes, that's better. Yeah.
Can you hear me better now?
Yes, that's better.
Okay. Okay, perfect. Right, so again, the agenda is triage and initial assessment, venous thromboembolism, antimicrobial treatment and protocol for our hospital, 2 case presentations and a conclusion. I'll speak fairly quickly because I know that we're limited with time. So our case definitions for coming into hospital is basically a patient who needs to come into hospital, having either clinical or radiological evidence of pneumonia, acute respiratory distress, or they've got influenza-like symptoms with fever, cough, and breathlessness. Mild COVID is mild symptoms, basically fever, fatigue, cough, with or without sputum production, anorexia, malaise, muscle pain, myalgia, sore throat, dyspnea. In mild cases, we don't usually give them any treatment. We don't usually admit them to hospital, and we send them home. Severe COVID, these are our criteria. They're not fairly specific, so we had to do a lot of clinical decision-making patient by patient. So if the patient is above 55 but fairly stable, we would still send them home. If they're immunocompromised but fairly stable, we'll still send them home. So these criteria, although they are our criteria for hospital, they allowed us to make individual decisions for each patient rather than follow a specific guidance. Even patients with biochemical changes with high D-dimers and elevated troponins or ferritin levels who were clinically stable, you would have still discharged into the community with a bit of outpatient follow-up. Obviously, if the patient is septic, they would need to be admitted, and the protocol is different. And people with septic shock, who are basically people who come in with COVID symptoms and are persistently hypotensive despite fluid resuscitation. And we've got patients who develop ARDS or acute respiratory distress syndrome, and these patients eventually do end up in the intensive care unit if they're well enough or fit enough to go there, not too frail, and we made a decision early on that they wouldn't be for intensive care. Moving on to this slide. Thank you. So our antimicrobial treatment for Chelsea and Westminster Hospital. So if they had mild COVID, we wouldn't give them anything and discharge them home. If they had severe COVID, you would give them 1 gram of amoxicillin orally or 2 grams intravenously 3 times a day, plus an atypical antibacterial, which is usually doxycycline, azithromycin, or a macrolide. If they had severe COVID with sepsis, we would escalate our antibiotics to ceftriaxone once a day with an atypical antibacterial cover as well, and a shot of amikase and a shot of aminoglycoside. If they had ARDS, we would just give them ceftriaxone, atypical antibacterial, but we would refer them on to intensive care at that point in time if they were deemed fit enough to go to intensive care. In terms of our VTE prophylaxis, that changed about 3 weeks into the COVID crisis at Chelsea and Westminster, because we noticed that patients had high D-dimers and had increasing D-dimers. So our usual patients who do come into hospital, whether they're COVID or not, we started them on VTE prophylaxis, which is venous thromboembolic prophylaxis, which is usually about 40 milligrams of enoxaparin or low molecular weight heparin once a day. But in COVID patients, our guidance has changed to BD dosing. And when patients were discharged home, we discharged them home on a DOAC, especially if they were in hospital for at least 7 days, or if at any point during their admission, they needed HDU or intensive care admission. For acute thrombosis, DOACs were not usually recommended in the acute phase. We used low molecular weight heparin or unfractionated heparin, depending on the renal function. And we monitored fairly closely for DIC and coagulopathy as well. So moving on, I'm going to speak about a couple of interesting cases. So I have a 40-year-old chap who initially had 2-week history of myalgia, sore throat, fairly specific for COVID as such. He attended a different hospital, and during his hospital attendance, which was less than a day, he was swabbed, and the swab came back positive for COVID, but a new murmur was heard, and he was discharged with an outpatient echo. He then developed fever, cough, and breathlessness since he was discharged from the other hospital, and he stayed at home, but when the breathlessness became too bad, he came into hospital. He came to our hospital. His white cell count was not raised, his lymphocyte count was normal, his CRP count was raised though. He had a normal hemoglobin with a low MCD, which was new to him. He wasn't aware that he had any hemoglobinopathies. He had a high D-dimer and high ferritin level and high LDH, and a normal troponin. His chest X-ray showed basically bilateral aerospace opacification, worse on the left-hand side. He had another COVID swab with us, which was again positive. And this man was very anxious. So although he didn't require very much oxygen, he only needed 5 liters per minute of oxygen by nasal specs. His respiratory rate was extremely high. It was 40 at one point in time. And he was complaining of a bit of pleuritic chest pain after coming into hospital, which developed in hospital. So he went on to have a CTPA, despite his D-dimer not being that raised. It was high, but not that raised. And this CTPA did show a subsegmental PE, and he was started on treatment dose enoxaparin. He received regular antibiotics. He would have fulfilled the severe COVID criteria, so he was given IV amoxicillin and doxycycline through 3 days. He had persistent fever, and then with the new murmur, it was thought maybe it would be best to cover him for infective endocarditis. He required CPAP for only 1 day, or actually it was just about 5 or 6 hours. And it was mainly because of his tachypnea rather than his poor oxygenation. This was stopped fairly quickly. We're moving on to the next. Thank you very much. So he was suspected to have endocarditis, not on a TTE. The TTE didn't show any vegetation. It just showed severe aortic regurgitation. Despite that, he was started on flucloxacillin, amoxicillin, and gentamicin to cover for endocarditis after discussion with both cardiologists and microbiologists. He was then transferred to tertiary center to have a TOE. But he never had a TOE. They reviewed his TTE and they felt confident enough that he didn't have a vegetation. So he was discharged home without any antibiotics. He had another CTPA in that tertiary center, which didn't show any clot. So he was discharged home without any medication. He presented the day after again to our hospital with worsening breathlessness and new right-sided pleuritic chest pain. And this is his chest X-ray. It basically shows, again, aerospace opacification, mainly in his upper zones, but it shows, which is quite rightfully reported as an encysted hydropneumothorax. But because of his degree of breathlessness, he went again to have another CTPA. Next slide, please. Thank you. And his CTPA did not show any clot, but it did confirm the presence of the encysted hydropneumothorax, which you can see with the blue arrow. He was treated initially with just analgesia, a bit of chest physiotherapy, and we restarted his anticoagulation again at a prophylactic dose, and we discharged him 3 days later once his pain settled. He went home, got worse, started developing a fever, and he was readmitted again. This time, the diagnosis was an infected, encysted hydropneumothorax. He had a raised CRP during this admission. He was started on intravenous antibiotics, and he also had some oral metronidazole, and he improved on that. So he had a hospital stay of about 5 days, and he was discharged on oral ciprofloxacin and metronidazole. If we can move on to the next slide, please. Okay. This is another view for the encysted hydropneumothorax. He continued on the ciprofloxacin and metronidazole for about a total of 3 weeks post-discharge, and he was reviewed on a weekly basis in our ambulatory care unit. His D-dimer started rising, and his breathlessness never went away. And despite having 3 CTPAs, the initial one showed a very tiny segmental PE, but 3 CTPAs after that with no obvious PEs, it was felt that he may still have some small PEs that we couldn't pick up on our CTPAs. And his D-dimer peaked to a peak of 2,500. So we discussed his case with hematology, and it was felt on balance of probability that he might have an underlying PE, so he was started on treatment dose DOAC. On both the antibiotics and the DOAC, he improved massively, and the last time he was seen was a few days ago, and he's like a different man. His X-ray changes and CT scan changes have improved as well, but not as much as he has clinically improved. If we can move on to the next slide. So the pre-treatment one is on the right, and his post-treatment one is on the left. And we can see the measurements of the pre-treatment one. And also we can see a lot of consolidation, both superiorly and inferiorly on the right side, and a little bit on the left, which have improved massively on his post-treatment one. But this man had a prolonged treatment for his encysted hydropneumothorax, and it's taken him quite a number of weeks to get over his COVID pneumonia. So if you move on to the other cross-section, and we can see here, it's a little bit clearer that the encysted hydropneumothorax is much smaller. It doesn't look like a hydropneumothorax anymore. There seems to be a bit of echogenic material there. So whether he's got encysted consolidation or of this fluid, it's difficult to say, but clinically he's much improved. If we can move on further. So like Marcela said, who's my ITU colleague, we usually do reviews for each of our patients, and patients who have stayed in hospital or have had recurrent hospital admissions or high morbidity, we reflect on what we did well and what we could have improved. For him, I think the initial treatment was totally appropriate. He had good follow-up plans made. He had a multidisciplinary team approach for his case, where we included both acute physicians, respiratory physicians, microbiologists, and cardiologists. We had the benefit of using our ambulatory care to give very good continuing care, and we had excellent communication between the teams. For him, what we could have done better, and it's easy for me to say in hindsight, maybe he shouldn't have been started on the CPAP because he only needed it for 5 hours. And I think there was a high element of anxiety there rather than actual indication for CPAP. But in the middle of the night, when you're the registrar on a busy take, you need to make a judgment call. And the judgment call was to put him on CPAP, and I support my registrar fully, but I don't think he needed it at all. His transfer documentation to the other hospital, his tertiary hospital, we should have suggested that he should have gone on an outpatient BT prophylaxis on discharge, which he didn't have as per our guidance. But I think that was missed because he was transferred on treatment dose to treat VTE, which was stopped on discharge from the tertiary hospital. I don't think he should have gone to the tertiary hospital at all, because what they did is basically just keep an eye on him and review his images. I think we could have done that remotely from where he was in our hospital, rather than transfer him to a different hospital for him to be discharged from there. So I think this is what we could have improved it on this case. I'm going to move on to the second case, as I know that we're running out of time. This is a 48-year-old gentleman who's a colleague who had SARS-CoV symptoms of fever, loss of smell and taste, and cough for about 12 days. And then he had 3 days worth of azithromycin. His symptoms then resolved. And because he was a colleague, he had to return back to work. And he was on call the first day back. And he then developed a headache and high fevers with temperatures of about 39 and some neck stiffness as well. And he felt that he wasn't functioning 100%. He couldn't think straight. He had some bradyphrenia. He didn't have any rashes or herpetic eruptions or anything. Examination, he looked quite unwell. He was photophobic. He had a normal neurological examination. His chest was clear, despite the fact that he had COVID symptoms a few days before. If you move on to the second slide. So in his case, his investigations initially, apart from an eGFR of 66, they were fairly unremarkable. He had a CT head and a CT venogram, which were normal, and he went on to have an MRI head, which was also normal. He had an LP because of the headache and the ongoing fevers. And his opening pressure was fairly fine. His CSF white cell count, however, was 125 with mononuclear cells, 98%, and a high protein of 1.57 grams per liter, the upper limit being 0.45. He had a normal lactate and a normal glucose, so it was suggestive of a viral meningitis. Picture. So he was initially started on ceftriaxone, but that was stopped after the CSF results, and we started him on acyclovir then. And then we got our CSF result back. If we move on to the next slide, please. And his CSF PCR basically didn't show anything apart from EBV, but he had low copy number. His SARS-CoV was also tested on the CSF. It was negative. Given the low number of EBV, our neurologist felt that on balance of probability that this was still COVID-related aseptic meningitis. And he tested positive on his nasopharyngeal swab again, but he didn't have any ongoing respiratory symptoms. So we stopped his acyclovir and he was discharged. For this case, what we did well is that we promptly rearranged ourselves to take over his service. So one of us fairly quickly came to do the on-take and post-take. We referred him to an external specialist. So one of our neurology colleagues took over his care so that we didn't have to make difficult decisions for a colleague. We could have done better. Analgesia, I think he was in a lot of pain from the first night. If we maybe gave him something stronger, it might have helped with his overall recovery. But also in our colleagues, we tend to not look after ourselves as medical care professionals. He had a prolonged course of respiratory symptoms. He also needed to have some azithromycin to improve his respiratory symptoms. And the
Sorry, Dr. Linah, I think we lost you. We lost your voice completely. We can't hear
he was
you.
on call. I think for him and for all our colleagues, post-COVID return to work chat or interview to see if they would be a better option for all of us. I think the best thing is, I'm going to disconnect me now.
Yes, we can hear you now, yeah?
Okay, perfect. So take-home messages. We need to approach these patients in a multidisciplinary team. So physicians, intensivists, respiratory physicians. We need to be able to communicate well within our teams, so good teamwork. Our vague case severity definitions to begin with in our hospital gave us our own room to clinically evaluate each patient and tailored treatment to each patient individually. Clinical judgment was the mainstay for both the diagnosis and management. And I think reflection is very important for all cases that we manage, whether they are admitted for a fairly short period or if they've had quite a complicated course of treatment. And thank you very much.
Okay.
Thank you.
Thank you very much, Dr. Linah Suleiman. That is a fantastic talk, and I think we would like to ask if there's any comment or question from the panel.
Dr. Saeed?
Yeah, assalamu alaikum. Interestingly, do you have available PCT in your hospital, procalcitonin, as a biomarker? Yeah.
We do have procalcitonin, but we only introduced that in April. So for the first case, the chap who came in with the insisted hydropneumothorax, when he initially was in hospital, he didn't have any procalcitonin, but subsequently he had procalcitonin levels which were quite normal.
Yeah, so in one of your protocols, in the mild, you were giving antibiotics upline, right? The front mild cases. What was
for our mild cases, we weren't giving any antibiotics at all. We were basically.
I must have not seen that slide. Yeah, it was mild to moderate. You had amoxicillin as a protocol for all patients, which I found interesting because it's a viral condition. It's only those.
So no, our antibiotics are only for severe COVID. So we didn't have mild. We basically had either mild COVID or severe COVID. We didn't have any moderate COVID. So for our severe COVID, we started with amoxicillin and an atypical. And severe COVID with sepsis, we gave a ceftriaxone and an atypical with a shot of amikacin. But we don't have moderates, and we do not advise or advocate antibiotics for patients with mild symptoms.
Okay, okay, fine. That makes sense.
Thank you. I think we have a question from the audience here. I think the question direct to Dr. Emmanuel. Is there any difference in resuscitation COVID from non-COVID patient?
So I think that's a very good question. I think a lot of the difference is around donning of the PPE before you start, and then the way that cardiac arrest is confirmed. So before, with the listening and the feeling of breath sound, so that's been removed from the algorithm. So you just feel for the pulse for 10 seconds to confirm cardiac arrest. So I think that's a significant difference between the COVID versus the non-COVID patient.
Thank you. And I think the second question also regarding the same topic, I think, with regarding the first responder in CPR patient in cardiac arrest. They asking, can the first responder start CPR with surgical mask only?
I think it's a really difficult, it's a difficult personal question. It's a difficult ethical question. What we know is that CPR is an aerosol generating procedure. And with aerosol generating procedures, you need the maximum protection that you can get. And that would be with an FFP2 or an FFP3 mask. So personally, I think if you had that available, I would recommend that you use that. It's also worth discussing it as a group before you have to encounter one of these scenarios and come to a consensus. With regards to CPR in the community, the advice is that you cover the victim or the patient's mouth and nose, and you wear a mask before you do CPR. But that's because that's anticipated that that's in the public, in the air, in the open, and we know that transmission is lower in the air or in open spaces, whereas confined spaces, CPR is aerosolized generating. But any comments from my further colleagues on the panel would be useful.
Okay, thank you. Over to you, Dr. Ahmed.
Yeah, I just wanted to ask Dr. Suleiman about the first case that you presented. It was a very interesting case with that patient who had a new murmur of and was subsequently found to have aortic regurgitation. Were there any blood cultures done in that patient?
Yes, and
because obviously that can sometimes guide your management.
so he had 3 sets of blood cultures, and all of them were negative. He had sputum cultures, urine cultures, everything was negative. So we never grew anything from him apart from the COVID PCR.
Okay, great. Thanks very much.
Thank you. And I think during Dr. Abi talk, I think we got a question from Dr. Saeed Ahmed. I think that question direct to Dr. Abi with regard the study endpoint was changed halfway through the study. Dr. Ahmed, would you like to?
Yeah,
go ahead
thank you
with your
very much,
question,
Dr. Abi. A great overview. So the studies for remdesivir, as Dr. Fauci from the States, who has been pushing them quite a bit, and he said a very interesting statement. He said this was the new standard of treatment. Well, it's nowhere near standard in this country to use remdesivir at this stage. And from my understanding, the study endpoint in the study that you pointed out maybe was changed halfway through the study. Study endpoint should have been a hard endpoint of mortality, but when the investigators were doing interim analysis, did not find that the hard endpoint would be reached. They went fishing for some positive endpoint, and the most positive they can point out is what you pointed out, was a recovery time being slightly quicker by 4 days. Now, I don't know if that is the case, but did you find that in your reading?
So thank you, that was a very good question. So when I looked at the papers that actually published and looking at the small points that was drawn up, that actually this study didn't reach total conclusion. As you know, there are other studies that currently are looking at remdesivir. So the recovery trial is looking at the use of remdesivir with other combination drugs as well. Yes, it didn't reach a statistical analysis kind of significance. It didn't reach a hard point. And I think it was cut shortly or abruptly because they knew that, you know, even if they ran this for another 2 years, they wouldn't achieve that data. And it was just, you know, I think what we need to do with all of these trials, take it with a bit of a pinch of salt. It did show some difference in the duration of the illness the patient had. I don't know if Marcela is still on board, whether she's had any experience with using remdesivir, because essentially, what, you know, they used it in kind of moderate to severe patients. Not a lot of these patients were on ECMO or mechanical ventilation. It may have a role, but I don't think the role is exactly known. You know, maybe it's to be used in a milder condition rather than severe condition. I don't think we're there yet, but yeah, there was a change in plan of that study, and I don't think it's currently protocol drug to use. It's on compassionate use in many places. Marcela, I don't know whether you've used it in ITU with any of your patients.
So basically, we haven't used, so basically, one of my problems, or our problem in intensive care, the disease progression will differ from one patient to another. So randomizing patients, into clinical studies when we didn't know the course of disease, we didn't feel it was right, because if the patient didn't have a cytokine pattern or thromboembolic pattern or was a mix of things, the drugs that we were introducing, the side effects were more, the patient were at high risk of dying because of side effects or complications of the drugs and not because of the disease. So as I said before, we moved to basics, understand the process of disease, understand the different times of the disease, so then we can introduce drugs accordingly. At the beginning, was very, very difficult to accept any clinical trial or randomize the patient into clinical trials because we didn't feel it was right for them. We were taking their chances away. And that happened actually in a lot of centers. And we proved to be right because a lot of studies actually show that were no benefits. And we need to start looking into more details of the patient who died in those clinical studies as well. So I think there is a lot to say. I think that we all learned from the research as well. So now probably the inclusion criteria for clinical studies will be modified, and that will help us to globally, not only in intensive care, but in hospitals and the community, to randomize the right patients into the studies. But that was our view at the beginning. So sorry, yeah.
Thank you for that.
Okay, thank you. Had anyone had any comment or any question? Dr. Hatim, Dr. Ahmed Adlan?
No, I didn't have any other questions actually. I think it was all quite very thorough. Thank you.
Maybe just one last question to Abby, if you don't mind. Abby, are you aware of any data in HIV patients who have been on antiretroviral therapy, whether that has any preventive role or made them less likely to contract the infection or made it less severe? I'm not aware myself of any data.
So there was, when I was looking at this, there was a couple of small studies that looked at small case cohorts of patients who were HIV, who had COVID-19. But again, these weren't any randomized control trials or big studies that could be quoted in numbers. What I can tell you from the HIV team, because I work quite closely with some of them, is that they are not seeing a huge number of patients with HIV that would come in with COVID-19. And I think one of the reasons they say it's not just because of the drugs, is that these patients are probably very good at self-isolation. They've learned, through life and experiences, how to prevent themselves from getting the flu virus and other infections. So there may be some behavioral learned kind of action that they are able to take better than the rest of the population. But in terms of, yes, maybe retroviral therapy is protective to some cases. I don't think we saw an influx of HIV patients with coronavirus during, the times that we thought that we would see an influx of them. So there may be some protective benefit from some of these drugs, but I think some of it is also environmental, as well as they're pretty good at kind of keeping themselves isolated and kind of shielding for long periods of time. And I think they've done, that's probably one of the success reasons we've seen little of these population present to hospital.
Thank you.
Okay, thank you very much, Dr. Abby, and thank you very much to everyone. I think we're going to bring this session to a close. It's been fantastic having you, and we're really pleased that you've made the time to join us in Chelsea and Westminster. So we would just like to remind everybody that we have another up and coming webinar for part 2 of webinar 4 on Saturday, and we would very look forward to for you to join us. So thank you very much, and I'd like to pass it on to Dr. Abdul-Azim.
Thank you very much, Ahmed, and I would like to give a big thanks to Dr. Abi and to Dr. Hatim and to Chelsea and Westminster Hospital team for this great initiative, and it was a fantastic talk. This talk is going to be ready in next few hours on the YouTube channel, and will be also published on Facebook, and we will pass it to you. And we will also be sending the question out to the audience for the assessment. I would be very grateful if all the speakers just can give us at least one question for each session, just to pass it on the assessment form. And I would like to ask Dr. Hatim just to close the session. Dr. Hatim Ali.
Thank you, Abdul-Azim. And I think it was a fantastic discussion, very practical points that was raised by all the speakers. Probably we meet on a daily basis in our practice. So I think it was very fruitful. Thank you very much to all of them. And many thanks to Abby herself for organizing all of this. And hope to see you in more collaboration in the future.
Thank you very much for the invite.
Thank you very much. Thank you.
Thank you. Thank you very much for the invite.
Thanks.
Thank you.
Stay safe.
Take care. Bye-bye, guys.
Thank you.
Bye.
Bye now.
Bye.
Thank you. Bye.